for IT's part. And we will get to public comment. When we do, you can send a message in the chat box or raise your hand, or we'll have comment in the room. We'll make sure that we capture your comment when we get there. And I think that are all. Oh, we'll do roll call voting per usual when we get to the time for voting. And so you can do aye, nay, or abstain once we get to our roll call voting. And for those of you who didn't notice, Dr. Ott made an appearance in the building. So some of you can come back too. We miss you all.
Oh, this is a one.
Is she lost?
Excuse me?
Is she lost?
Am I lost? No, I have to be somewhere in Indianapolis at noon, so that's
Okay.
why.
Well, welcome. Great.
Well, thanks, DR. I appreciate that. Welcome.
Just try to get out of the parking lot.
Okay, that was an evil laugh.
All right, well, Dr. Marshall, I will turn it over to you for the call to order and your remarks.
I have no remarks today.
All right, opening comments from OMPP, somebody in the room or?
Yeah, no, we have none. Leslie is,
she's here.
There you go.
Hi.
Awesome.
Hi, everybody. No opening comments from OMPP today. Well.
All right, thank you. That takes us, Dr. Marshall, to approval of the minutes.
Okay, are there any addition or corrections to the minutes? If not, may I have a motion and a second?
Chris Johnson, motion. Seconded.
All right, we have a motion and a second. Dr. Marshall.
I abstain. I wasn't there.
Okay, Dr. Klass.
I also abstain.
All right, Ms. Fippen.
I wasn't there either, so I abstained.
Mr. Johnson.
Approved.
Dr. Ott. Aye. Dr. Simon.
Aye.
Dr. Toma.
Aye.
Dr. Treadwell.
Aye.
And I believe we had to lose Dr. Williams, so we've got 1, 2, 3, 4. Is that gonna? Do we know? Does that count?
How many?
We had 4 ayes and 3 abstains. Abstentions.
I think that passes. It's a majority, and we have quorum. So.
Okay.
Yeah.
All right. Well, then that motion will carry. We have decided that motion will carry. Thank you.
Just got to have a majority.
All right. Next item on the agenda then is Dr. Weber is expiring on the therapeutics committee. So you all, I believe he has said that he would like to continue. Should you all vote for him to continue?
Any questions or concerns? If not, may I have a motion and a second to approve Dr. Weber on the board?
This
I'll
is
move to
Pat.
approve.
I move to
I got
approve
a
Dr.
question.
Weber.
I have a question, Amanda. Is
Yes.
the agency supportive of Dr. Weber's reinstatement or continuation on it?
Yes, we
I'm
are.
seeing head nods, yes.
Asked him to, if he would be so kind as to consider. We wouldn't put him up if we didn't approve.
Good. Okay. I second it.
All right, well, we had a motion and a second with Dr. Ott and Dr. Treadwell, so we're good. So I'll take the roll call. Dr. Marshall.
Yes.
Thank you. Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Yes.
Dr. Ott.
Aye.
Dr. Simon.
Aye.
Dr. Toma.
Aye.
And Dr. Treadwell.
Aye.
All right, thank you. We have all ayes, so we will congratulate Dr. Weber and let him know. No, she had to leave. Okay. We will then move on to our PA stats for July. So overall in July, we had I've got a phone number. Somebody's phone number I'm probably going to mute. I don't know if it's...
Just hit mute.
to see if this, better now? Yes, okay. I think he's okay. I think it's. All right, so overall, we had a little over 17,000 approved, which was 72%, and just shy of 7,000 denied at 28%. I gotta subtract over here. Okay, so then in our point of sale quick check, we had just shy of 14,000 approved, which was 74%, and 26% denied. 21% of those denied claims went to the call center, where 81% were approved and 19% were denied. And then on the manual PA side, we had 51% approved and 49% denied. I think the trending graph is helpful here. You can see a slight decline again into the June and July, which is what we expect to see every summer. We tend to see it, especially on the mental health side. We see a decline in stimulants and some other PAs. So nothing real surprising here with what we would expect to see in the month of July. When we look at our top 10, you could still see stimulants, opioids, and antipsychotics are in the top 3, but again, stimulants are down from what we usually see in our back to school months, so I do expect to see August probably start to climb back up again. And then on the manual PA side, early refills, our mental health quality advisory committee utilization edits, and quantity limits were our top 3.
Can you go back?
To the side or one?
This slide, yeah, I'm just wondering how the clonidine guanfacine duplicate therapy.
So
is that usually cross titration?
The vast majority of them are approved because we have to check all the claims to validate. So we're checking all clonidine, all guanfacine claims to validate that there isn't duplicate therapy. So that's why you see the high rate of approval requests, because they either don't have duplicate therapy or they're using a long acting and a short acting, so it's not considered duplicate therapy for them.
Okay.
And then those denials you see are the ones that are duplicate or above.
Okay, thanks.
Mr. Johnson, I see your hand raised.
Yeah, Amanda, I was looking at the PPIs. What is it that's caused the majority of PPIs to be denied when they're submitted for PA requests?
Yeah, so the PPI rule is around exceeding 90 days of therapy continuously. And so we do have diagnoses that bypass that edit. So certain things that we know are going to require long-term PPI use, as well as people that are on drug therapies that may require long-term PPI use, like long-term NSAIDs or steroids, those kinds of things. So we do have a fair amount of denials of people who just still want to continuously use PPIs without a trial of a taper or H2 intermittently. And so we see those denied in point of sale quick check, and then they may come to the call center after that for further review to provide us additional information that maybe we didn't have when we were reviewing here. But that's the predominant reason for the denials. There could be some as it relates to non-preferred in here as well, but the vast majority are usually exceeding that 90-day continuous use.
The anti-seizure, anti-migraine, are they off-label uses, or is that what I use right now?
Anti-seizure is typically non-preferred situations. So our non-preferred anti-seizure going through there, we do have several things that will bypass that non-preferred editing. And looking if they've utilized that therapy before, and if we have editing around the brand product to be able to validate that as well. And then the anti-migraine agents is also typically non-preferred situations where they're not meeting, or they're trying to get to an injectable and they haven't trialed oral therapy prior or trialed any of the other maintenance meds.
Yeah, thank you.
Any other questions? All right. We will move on then to our opioid stats. So we did have a decrease in July, as again, overall, we just kind of had a decrease of all of our PAs in July, and decrease in utilization. So decrease in our total utilizers just slightly, and decrease in our new utilizers by a little over 9%. Our 18 years of age members are hanging about the same and around the same day supply. They're still hanging under 5 days. You can see our number of utilizers broken out, and then those that are PA exempt. So just a reminder, all of our utilizers in the greater than 500 MME are PA exempt. We're currently at 450, making our way to 425 on October 1st. So we're in the 450 space right now. When you look at our 90 and above, you can see the trending here for those individuals or the overall utilization. Again, the less than 90 is not on here since it would skew the graph, and the vast majority of our patients are in the less than 120 range, so small numbers in our other groups. When you look at our overall trending, again, just a reminder, the green teal color is the current utilizers greater than 18, the cranberry is new utilizers, and the purpley blue at the top is the less than 18-year-olds. We can see that slight decrease overall and decrease in new utilizers that happened in July. And again, something that we do tend to trend through. You can even see like August was a little bit lower, more in line with what July was in the previous year. So that's really what we're experiencing here. And then you can see our less than 90 really seems to go down significantly. Again, we don't have a ton of patients in our utilization, so it can definitely skew the graph, but this is really, I think, reflective of showing our new utilizers have decreased because our new utilizers stay in that less than 90 group. And so showing that they are decreasing out is also showing that our less than 90 decreases, so that's not really surprising when I look at this graph. And then in our 90 and above, you see a slight increase in the 90 to 120 there at the top, but it is pretty small and overall, fairly consistent with where it's been. And again, these are really small numbers in this graph. And the 250 to 500 is fairly steady. As we go down, we'll expect to see that graph kind of go down and then see people kind of move through that again. So again, nothing really surprising in these graphs, kind of what we would expect to see right now. Any questions or comments on that before we get into the MHQAC utilization edits? All right. So the MHQAC is recommending a couple of utilization edit updates on the WAKIX 4.45 milligram tablets and the 17.8 milligram tablets. They were at 2 per day, but updating their age to 6 years of age and older. And then we also have a couple of PA updates. So for the WAKIX, updating the PA criteria to include the age expansion for narcolepsy with cataplexy or excessive daytime sleepiness for those 6 years of age and older. It was previously at 18. So again, this was the update that we just recommended just a second ago. And then on the antipsychotic agents PA for duplicate therapy, currently we have in the PA that if they're utilizing duplicate therapy, that the antipsychotics involved in the duplicate therapy need to be prescribed by or in consultation with a psychiatrist. We would like to add or psychiatric specialists to try and include some of those nurse practitioners that have specialized in the psychiatric space so that we can kind of open this up a little bit more to those providers to provide that care. Any questions, concerns, or comments on the Mental Health Quality Advisory Committee's recommendations? If not, if I could get a motion in a second, please. Oh, Mr. Johnson, I see your hand up.
Thank you again. Hey, Amanda, with the WAKIX, do we make any distinctions with narcolepsy with or without cataplexy? With cataplexy, obviously, would be an accepted medical indication, but without cataplexy, do we step through stimulants or anything like that first, given the high costs associated with this product?
Oh, we're pulling that criteria up just a second. Sorry, I don't remember the entirety of the criteria off the top of my head.
We chose our indications based on what was studied. Sorry, my computer is going very slow.
Just a moment. Thank you for your patience. Sorry, I don't have good hold music. Do you need me to turn?
Yeah, my hotspot is very slow.
I can bring our satellite dishes next time. Right. From our camping. Okay, so on WAKIX, we have, the member is 6 years of age and older and has the following diagnoses: narcolepsy with cataplexy or excessive daytime sleepiness, or member is 18 years of age and older and has the diagnosis of obstructive sleep apnea, hypopnea syndrome with residual excessive daytime sleepiness in conjunction with appropriate medical interventions, and they've trialed armodafinil or modafinil, or they provide medical justification for use over that. So there's a diagnosis. These are based on exactly what they're approved for. So it's narcolepsy with cataplexy or excessive daytime sleepiness.
That's not true.
Okay, so no step on the cases, narcolepsy cases, without cataplexy.
We can't step the mental health diagnoses through anything because they're preferred agents.
Correct.
All mental health is preferred.
82% of the patients studied for this indication had cataplexy.
Okay.
So we
So-
included both.
On that antipsychotic agent addition, I do agree that it's probably a good idea to allow the NPs to be the consultant. But I also would think that given that they all should have psychiatrist collaborators, I don't know if there's a way to do it, but if we could try to ensure those are cases that are getting staffed with their collaborators, I would think would be a good idea.
Oh, I can do that. Okay. So, Dr. Klass, you bring up a valid point, and we have not moved on like the nurse practitioners or the PA role for a while, but we've been experiencing some non-psychiatrist intervention in these, where so we have nurse practitioners that have a psychiatric specialty, and they are deferring to their physician who actually is not a psychiatrist. And so this really brought the whole situation to light, and because nurse practitioners have prescribing authority, we have chosen to, or we're recommending that we actually consult with them versus maybe the doctor that they get sign off on that may or may not actually even be a psychiatrist. We've had some experiences with that, so that's sort of why we're going in this direction. Yeah. Yeah, but we'll monitor, and if we have to figure out something later on, we will. Good point, though. Thank you.
Dr. Powell, I see your hand raised. You have a question?
I do, thank you. Just with regard to the criterion or the specification of appropriate medical interventions, could you please provide an example of what is meant by that? So, for instance, WAKIX is indicated or covered for obstructive sleep apnea, hypopnea syndrome. Right. Yeah. So what examples of appropriate medical interventions are there? Is that like sleep hygiene, that sort of thing?
So not only sleep hygiene, but also that they're using like their appropriate CPAP machine, or that maybe they have an oral device that the oral appliance that they use, like that they're actually trying to treat their sleep apnea first without just like letting their sleep apnea run untreated.
Great. Thank you for that.
Sure. Any other questions? All right, if not, if we could get a motion and a second then.
I'll move to approve.
Do we have a second?
Dr. Marshall, second.
All right, we have a motion and a second. Dr. Marshall?
Aye.
Dr. Klass?
Aye.
Ms. Pippin? Ms. Pippin, you might be on mute. Okay, thumbs up. We'll take a thumbs up. All right. Mr. Johnson?
Aye.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
And Dr. Treadwell?
Aye.
All right, we have all ayes, so that motion will carry. Thank you. All right, we're about to go through all of our therapeutics committee recommendations, so we'll go through them kind of therapeutic group or class, and we'll take motions as we go through each one. So we'll start off with the respiratory recommendations. The therapeutics committee has no recommended changes in the classes listed here.
We can't unmute her.
Oh, I think it's,
There's a star or something that they can press. It's a star 6. It used to be back in the day.
star 6.
It used to be back in the day.
Ms. Pippin, you might be able to try star 6 and see if that unmutes your phone. Okay. In the beta adrenergics and corticosteroids, for the Advair discus, moving to preferred and adding to the preferred brand drug list and maintaining its quantity limit, and then the generic Advair discus, the fluticasone salmeterol, moving to non-preferred and maintaining its quantity limit. And then for the beta agonist short acting, for the albuterol HFA, moving to non-preferred, maintaining its quantity limit. The Pro-Air HFA is no longer manufactured in CMS terms, so that will be removed from the SUPL. Pro-Air Respaclick will be moved to non-preferred, maintaining its quantity limit. And then the Ventolin HFA, we're adding to the preferred brand drug list and maintaining its quantity limit. And then Proventil HFA is no longer manufactured in CMS terms and removing that from the list as well. So you may be asking yourself, well, it seems like you just removed all the albuterol HFA products or moved them to non-preferred, and that is correct, except for the Ventolin HFA, which will be our preferred product. We have verified with the manufacturer that there is plenty of stock, that there shouldn't be any concerns with supplying this, and there are several other states that also only have Ventolin HFA as preferred, so we're confident that they will be able to supply the albuterol HFA needs. For the respiratory and allergy biologics, Dupixent, maintaining its current status, but updating the PA criteria for eosinophilic esophagitis. Indication to include a trial and failure history of eohilia, which is a budesonide product, for at least a 12-week course for those 11 years of age or older, or valid medical justification for use. And that concludes.
Move to approve. This is Pat.
I'll second.
All right, we have a motion and a second. Dr. Marshall?
Aye.
Dr. Klass?
Aye.
Ms. Pippin?
Aye.
We can hear you, hooray. Mr. Johnson?
Yes.
Dr. Ross?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
And Dr. Treadwell?
Aye.
All right, we have all ayes. That motion will carry. Thank you. On to the anti-infectives recommendations. The Therapeutics Committee has no recommended changes in the classes listed here. For the hepatitis C agents, Vicuropac is finally no longer manufactured in CMS terms, so we can finally remove it from the PA criteria as well as the SUPDL. For the ophthalmic antibiotics, azazite solution moving to preferred, neomycin, polymyxin B, gramacin solution moving to non-preferred, Tobrex ointment moving to preferred, and then the Gentac ointment is no longer manufactured in CMS terms, so removing that from the SUPDL, and then the levofloxacin solution is no longer participating in the MDRP or the rebate program, so removing that from the SUPDL. For the ophthalmic antibiotics and corticosteroid combinations, blephamide SOP and Pred-G and Pred-G SOP are all no longer manufactured in CMS terms, so removing those from the SUPDL. For the odic antibiotics, Odoprio is also no longer manufactured in CMS terms, so removing that from the SUPDL. For the systemic antifungals, for the itraconazole solution, maintaining its current status but updating its step therapy, that they must have trialed and failed all the preferred agents, or must provide medical justification as to why each of the preferred agents is not appropriate, such as their infection is not susceptible to one of the preferred agents would be an example of that. And then they must be 12 years of age or under, or unable to swallow the capsules, tablets. And spoiler alert, the exact same thing on the voriconazole suspension, maintaining its status but updating its step therapy with the same thing I just rattled off. For the topical antifungals, just as an FYI, the Exelderm cream and solution, the brand only were removed because they're no longer participating in the MDRP. Mycosal AL 1% solution, adding to non-preferred, as well as the Mycosal HC gel and liquid, also adding to non-preferred. And then the Saconazole cream and solution also removing from the SUPDL since it's no longer participating in the MDRP. For the vaginal antimicrobials, metronidazole tablets adding to preferred and tenadazole tablets adding to non-preferred with step therapy, that they must have trialed and failed metronidazole, or provide medical justification as to why it is not appropriate for use. Again, being that the infection is not susceptible to metronidazole would be an example of that. For Solosec, moving to non-preferred, and then Zacchiato moving to preferred with step therapy, a previous trial and failure of a preferred topical antibacterial agent. And that concludes the anti-infectives agents.
Any
questions or
discussion?
concerns?
Yeah. If
Hi,
not,
yes,
can I have a motion?
Sorry, it's Wendy Powell. I do have a question. Could we go back one slide, please? Thank you. So on the Zacchiato, it looks like preferred topical antibacterial. You mean vaginal, correct?
Correct.
Okay, thank you.
Any other further questions? All right, if we could get a motion in a second, please.
I'll move to
Hi, this
approve.
motion approved. I'll second that.
All right, we have a motion and a second. Dr. Marshall?
Aye.
Dr. Klass?
Aye.
Ms. Pippin?
Aye.
Mr. Johnson?
Approved.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
And Dr. Treadwell?
Aye.
Thank you. We have all ayes, so that motion will carry. That takes us to the cardiovascular recommendations. The Therapeutics Committee has no recommended changes in the classes listed here. For the ACE inhibitor combinations, the Therapeutics Committee recommends that captopril hydrochlorothiazide be added to non-preferred, and then the quinapril hydrochlorothiazide move to non-preferred. For the miscellaneous cardiac agents, the Entresto sprinkle capsules be added to non-preferred and added to the cardiac agents PA with drug-specific PA criteria. And that concludes the cardiovascular agents. Any questions or concerns?
Chris Johnson, motion approved.
Last second.
All right, we have a motion and a second. Dr. Marshall?
Aye.
Dr. Klass?
Aye.
Ms. Pippin?
Aye.
Mr. Johnson?
Aye.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye. Aye.
and Dr. Treadwell.
Aye.
All right, thank you. We have all ayes, so that motion will carry. In the lipotropics classes, we have no recommended changes in the classes listed here. For the fibric acid derivatives, Antara capsule removing from the SUPDL as it is no longer manufactured in CMS termed, and then the fenofibrate micronized capsules, the generic Lofibra, moving to preferred. In the lipotropics class, Praluent maintaining its current status, but updating the PA around an age expansion for heterozygous familial hypercholesterolemia indication in those 8 years of age and older with their respective quantity limit updates. And that concludes the lipotropics recommendations.
Chris Johnson, motion to approve.
This is Lynn, second.
All right, we have a motion and a second. Dr. Marshall.
Aye.
Dr. Klaas.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Yes.
Dr. Ott. Aye. Dr. Simon.
Aye.
Dr. Toma.
Aye.
And Dr. Treadwell.
Aye.
All right, thank you very much. We have all ayes, that motion will carry. For the anti-migraine recommendations, a few changes here. So Amavig recommending moving to preferred and updating its PA criteria to align with the preferred CGRP injectables while maintaining its quantity limit. And then for the preferred agents, so you'll see this in Joby and Emgality, maintaining their current status and maintaining their quantity limit, but updating their PA criteria regarding trial and failure history to a single agent listed within any of the 4 categories. So that being anti-seizure agents like topiramate, beta blockers, tricyclic antidepressants, or valproic acid or derivatives. And this is really around the updated guidance where we're just going to have 1 trial and failure of an agent instead of 2, since the injectable agents were brought forward as being a valid kind of first line option for prevention. So you'll see the same thing under the Emgality that I just mentioned. And then Qulipta maintaining its current status, but since we did move over Amavig, updating its PA criteria to step through 2 of the 3 preferred injectable migraine prophylaxis agents. So they won't have to try all 3, but continue at 2 of the 3, and then maintaining its current quantity limit. And that concludes the anti-migraine agents. Any questions or concerns on those?
No, Chris Johnson, motion to approve.
Sorry, before we move on, is there a reason we have to have tricyclic antidepressants there, since I know neurologists will use newer antidepressants as well?
So the tricyclic antidepressants are what are currently in guidelines for the prevention. So we're listing straight from the guidelines the agents that they recommend for prevention.
Well,
I'm not aware, I don't think any of the other newer antidepressants have been added yet into the guidelines.
If we can look at that to see if any of them have an indication in migraine therapy.
Yeah, duloxetine gets used commonly.
And we can check compendia too.
Duloxetine is used commonly.
Yeah, I know there's no indication, but I don't know about compendia.
Yeah. Well, we will take that back and check and make sure, one way or the other. Thank you. Yep.
If there is something there, we'll talk through adding that and getting that added in. Any other questions or comments? We have a motion.
Second. Dr. Marshall.
All right, we have a motion and a second. Dr. Marshall?
Aye.
Dr. Klaas?
Aye.
Ms. Pippin?
Aye.
Mr. Johnson?
Approve.
Dr. Ott? Aye. Dr. Simon?
Aye.
Dr. Toma?
Aye.
And Dr. Treadwell?
Aye.
All right, we have all ayes, that motion carries, thank you. For the electrolyte depleters, just for completeness of this class, we're adding Kionex, which is the SPS suspension, to non-preferred, and the SPS powder to preferred. That concludes the electrolyte depleters. Any questions or concerns on that class?
Chris Johnson, motion to approve.
Second. All right, we have a motion and a second. Dr. Marshall.
Aye.
Dr. Class.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Aye.
Dr. Ott.
Aye.
Dr. Simon.
Aye.
Dr. Toma.
Aye.
And Dr. Treadwell.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. For the multiple sclerosis agents, we do have a little bit of movement here as well. So the Ampyra brand moving to preferred and the preferred point of sale quick check PA criteria. Plegridy moving to non-preferred and the non-preferred two-step point of sale quick check PA criteria. And then Tysabri moving to preferred one-step position in the one-step PS, the point of sale quick check criteria. And this was around having a higher efficacious agent in a quicker way to access. So that's why the Tysabri is moved up into the one-step position. And that concludes the MS agents.
Dr. Class, move to approve.
I'll second.
All right, we have a motion and a second. Dr. Marshall.
Aye.
Dr. Class.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Yes.
Dr. Ott.
Aye.
Dr. Simon.
Aye.
Dr. Toma.
Aye.
And Dr. Treadwell.
Aye.
All right, thank you. We have all ayes. That motion will carry. We will move on to our targeted immunomodulators, and probably should buckle up for this one because we've got a lot going on, as we often do whenever we get to this class. So the first thing that I want to mention is we would like to update the PA around the non-preferred agents for the one-step to preferred agents one-step. And so what we're really trying to do is mimic our MSPA, where we have preferred and then preferred one-step and then non-preferred two-step. This is just going to hopefully allow us in some of our negotiations to be able to negotiate better and have some consistency between those PAs. So everywhere we had a non-preferred one-step, we're going to move it to a preferred one-step. So you'll see it on that side. We also have several new biosimilar agents. So a Humira biosimilar adalimumab, the generic for the Euflema, adding to non-preferred and the non-preferred two-step position. The adalimumab generic for Simlandi, adding to non-preferred and the non-preferred two-step position. Kevzara moving to preferred one-step and the preferred one-step PA criteria, and adding the indication of polyarticular juvenile idiopathic arthritis in those who weigh 63 kilograms or greater to the approval criteria. For Rinvoq, moving to preferred and the preferred one-step PA criteria, with also adding an indication of polyarticular juvenile idiopathic arthritis to the approval criteria. Rinvoq LQ, adding to preferred and adding to the preferred one-step PA criteria. Simlandi, adding to preferred and the preferred PA criteria. Skyrizi, maintaining its current status, but adding indication of ulcerative colitis to their approval criteria. Spavigo, maintaining its status, but updating the age limit to 12 years of age and older, or weighing greater than or equal to 40 kilograms. Tofidence, which is a new biosimilar for Actemra, adding to non-preferred and the non-preferred two-step PA criteria. It is for Actemra, right? Okay. Had a moment there. And then Tyan, also a new biosimilar for Actemra, adding to preferred and adding to the preferred PA criteria. We are keeping the Actemra as preferred right now just because Tyan does not have all of the indications that Actemra does. So once that happens, there is likely that there may be some shift at that point. And then lastly, Zimfentra is a new infliximab biosimilar, adding to non-preferred and the non-preferred two-step PA criteria. So I know that was a lot that we just went through, a lot of new biosimilars and some new agents and indications. Any questions or comments on those? All right, hearing none, if I could get a motion in a second, please.
Amanda, I got a question. What was the rationale of keeping Tremfya on non-preferred, or is there a rationale on that? In discussion, dermatologists, and that I think they're regarding the Tremfya and Skyrizi as being more effective than things like the Stelara and other products. And I just didn't know if we were leaving effective products on formulary versus effective formulary selections versus non-preferred selections.
So some of this review came down to second session price review. There also, as I'm aware, there's other efficacious agents in the preferred section that have similar mechanisms of action, because we always make sure that we have that captured. So we felt comfortable with the therapeutics committee obtaining in that space.
Are there any systematic reviews that compare this class at all that would show that, like an evidence base to justify it?
So they do, some of them do have some head-to-head trials, but they're usually against like Humira or maybe one other agent versus like the group as a whole. So there are some comparator data, but they're not, like, just because of the way they do the studies, a lot of times it's hard to get a really true comparison of this group.
Okay.
And it also depends on the indication. So, if there's one that has a unique indication, even though it may be sitting in a two-step category, if that member has that particular diagnosis, they would get approval for that.
Alaris is a great example of that. It has very obscure indications that pretty much nobody else has. And so even though we put it in the non-preferred two-step position, if they have that indication, they're going to get it.
Well, I guess if those dermatologists have an evidence base, then if they could provide it, that would help.
Yep. And we do consider that when they submit. Yep.
Any other questions or comments?
Nope, thank you.
All right, if I could get a motion in a second, please.
This is Carol. I'll move to approve.
Second, Dr. Marshall.
Thank you. We have a motion in a second. So Dr. Marshall.
Aye.
Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Yes.
Dr. Ott.
Aye.
Dr. Simon.
Aye.
Dr. Toma.
Aye.
And Dr. Treadwell.
Aye.
All right, we have all ayes, so that motion will carry. We're almost at the end of our therapeutics committee review. We did do an insulin's off-cycle review, as you remember. We talked a fair amount about the AMP cap and some of the changes there, and wanting to make sure that we reviewed pricing as we went through. So the therapeutics committee has no recommended changes in the classes listed here for the insulins. And then for the insulin's intermediate acting, the insulin aspart 70/30 flex pen and vials, which is the Novolog mix authorized brand alternative, moving to non-preferred. And that concludes the insulin's off-cycle review. Any questions or comments there? If not, if I could get a motion in a second, please.
Dr. Marshall, move to approve.
Dr. Klass, second.
All right, I have a motion in a second. Dr. Marshall.
Aye.
Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Yes.
Dr. Ott. Aye. Dr. Simon.
Aye.
Dr. Toma.
Aye.
And Dr. Treadwell.
Aye.
All right, thank you. We have all ayes. That motion will carry, and that takes us through the therapeutics committee. I wish I could say we are almost done, but we still have quite a bit to go. So thank you for bearing with us. Next up is the update for managed care pharmacy. Any update from the MCEs today?
No.
I'm getting a lot of no head shakes, so I think
Nothing
we are
for
good there.
MD-wise either. Sorry to overspeak, sorry.
No, you're fine. Thank you, Wendy. All right, that will take us then to our new drugs for review. Adstiladrin. We even listened to it. I should have remembered. Because we were trying to decide where the emphasis was. And so Adstiladrin, PA. So the criteria for this will be the member must be 18 years of age or older, have a diagnosis of high-risk BCG unresponsive non-muscle invasive bladder cancer with carcinoma in situ, with or without papillary tumors, and then prior history of at least 6 months of intravesical BCG therapy, or that the prescriber has provided medical justification for use over BCG therapy. And that concludes that PA. For the complement inhibitors, we looked this one up as well, and still don't fully understand the pronunciation. It's either Piaski, Piasky. So if anybody ever wants to let us know how this is really supposed to be pronounced, that would be great. I'm gonna go with, I was calling it Lucy in the Sky with Diamonds earlier, so we can call it Pia in the Sky with Diamonds, whatever works. So they must meet all of the following: diagnosis of paroxysmal nocturnal hemoglobinuria as confirmed by high sensitivity flow cytometry. Members 13 years of age or older and weighs greater than or equal to 40 kilos, should be prescribed by own consultation with a hematologist. And they need to meet one of the following: previous trial and failure of Solaris or Ultomiris as supported by claims history and chart documentation, or medical justification for use over those agents. The prescriber attests that the member does not have unresolved serious infection, and we list the infections there. They need to be enrolled in the REMS program, and that they will not be using it in combination with another complement inhibitor. And then the doses are listed there for you for induction and maintenance. And then the reauthorization criteria is history of the agent for 90 of the past 120 days. And then again, prescriber is confirming or attesting that they don't have a serious infection caused by one of those things if they're not using it in combination with another complement inhibitor, and that they continue to show positive clinical response as confirmed by chart documentation. And then we have the maintenance doses listed there for them not to exceed. All right, in the phosphodiesterase inhibitors for COPD PA, which we previously just called Daliresp now has another product, DUR. The initial authorization is that the member has a diagnosis of COPD. They have an FEV1 FVC ratio of less than 0.7 as measured by spirometry. The member has a modified medical research council dyspnea score of greater than or equal to 2. And they need to have one of the following. They need to be utilizing combination long-acting beta agonist therapy with a long-acting muscarinic agent antagonist and inhaled corticosteroid. So LABA/LAMA and an ICS therapy for at least 90 of the past 120 days, or that they're providing medical rationale for use over that combination. And one of the following, that they've utilized LABA/LAMA therapy for 90 of the past 120 days, or they're providing medical rationale for use. So I know that may sound a little bit confusing, but basically what we're saying is you should have tried the triple therapy first for at least 90 of 120 days. If for some reason you can't utilize the triple therapy because let's say you can't use an ICS, then you should have at least tried to use LABA/LAMA therapy or have some rationale for why you're not using the combination as well. And then the prescriber will attest that the member will continue to use their appropriate adjunct therapy while on DUR. And then the reauthorization criteria is history of use for 90 of the past 120 days, and that they're continuing to use their adjunct therapy, or rationale as to why they can't use their adjunct therapy. That takes us through our new drugs. Any questions or comments on all of those? Or anybody know how to pronounce Piasky or Piasky?
My friend's name is Piansky, and it only has an extra letter, an N, so.
So it could be Piasky. We could go with that.
We'll just trust Beth on that.
Right.
Well, let's just go with that.
It seems reasonable.
It's Piansky, so Piasky.
If no questions or concerns, if we could have a motion in a second, please.
Dr. Marshall, move to approve.
Chris Johnson, second.
All right, we have a motion and a second. Dr. Marshall?
Aye.
Dr. Class?
Aye.
Ms. Fippen?
Aye.
Mr. Johnson?
Yes.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Did you say Toma or Treadwell?
Toma.
Aye. Sorry, I thought we skipped me.
No, you're fine. Dr. Treadwell?
Aye.
All right, we have all ayes, so that is approved. The next item on our agenda is liaison with other boards. Any liaisons? All right, I am hearing and seeing none, so that will take us to public comment. We'll first start with if there was any public comment in the room, which I am getting a head shake that there is none. So let me go to our chat box. So it looks like the first up that we have is Jordan McClin with the Duchenne muscular dystrophy. Jordan, if you would like to begin speaking.
Hi, my name is Jordan, and I am a 15-year-old living with Duchenne muscular dystrophy. I just started high school, and I also recently started taking the new FDA-approved drug called Duvizat. I also have been taking deflazacort since I was 4 years old, and a weekly exon skipping infusion called Viltepso for more than 7 years now. Those are both FDA-approved drugs. Duchenne is a progressive disease that causes muscles to waste away. I am very thankful that I have been able to take this combination of drugs that have been created to slow the progression of my disease. They are helping me have a better quality life. We don't have a cure for Duchenne yet, but I know we are close, and I believe the cure can happen in my lifetime. While we wait for that, our best hope is to be able to use a combination of drugs that all do different things to help. Duvizat works differently than my exon skipping drug and my steroids. I can vouch for that because I noticed I feel a lot stronger. I heard that Indiana Medicaid wants boys to be declining on steroids before they can take Duvizat, or that doctors have to choose Duvizat over the steroids in order for the insurance to pay for it. When boys are declining, it means they are losing some of their muscle, and right now we don't have any way to get that muscle back. Time is muscle, and it feels unfair to make boys like me with Duchenne have to lose muscle before they can try this along with steroids. I want to make sure all boys who want to have this treatment can have it even before they start declining. Please take out the language that says patients need to continue to decline on steroids before being able to take steroids and Duvizat together. Boys should not have to be declining on steroids to take this drug. All the boys in the clinical trial were also on steroids and Duvizat. Also, even though the boys in the trial were all still walking, the FDA label does not say this drug should only be for boys who can still walk. I know the boys in the clinical trial were able to walk, but that does not mean the drug won't help boys who use a wheelchair to help them get around. There are lots of things we use our muscles for besides walking that are important to us. For example, being able to feed ourselves and being able to hug people. Also, a lot of boys love to play games and build Legos, and they can't do that if their arms and hand muscles decline. This year at MDA camp, I met a friend with Duchenne who could not play games with us because of Duchenne. It made me very sad, and I want him to be able to take Duvizat. I also have a lot of other friends with Duchenne who can't walk, but still want more time to be able to do other important things. Time is muscle, and every muscle in our body is important to us, not just the ones that help us walk. Can someone please ask for another vote on this policy today to take out those exclusions before it goes into effect on September 1st? The policy feels a little unfair right now. Thank you for listening to me today. I hope you will think my words matter and that they make sense to you.
Thank you so much for speaking with us today. We really appreciate you coming in and taking your time to do that. Any questions or comments from the board that you would like to ask Jordan?
I just want you guys to please ask for another vote on this policy because this policy feels very unfair to me.
Amanda, this is Chris. Is there any way we can revisit that policy?
Chris, it's, we have actually had a lot of discussions internally about this agent and about how the manufacturer studied the drug. All the patients were already on corticosteroids. So we're kind of, really what we have done is set up our criteria to kind of follow exactly what the doctors and the manufacturers did in the protocols for the study. So the patients were already on corticosteroids. So our criteria just says, again, that you have tried and you're continuing to decline. Of course, as this young man unfortunately knows, muscular dystrophy is a chronic and progressive disease, and having a wife with multiple sclerosis, I definitely can understand and feel what he's kind of his concerns are. But we also have to look at how the drug was evaluated in clinical trials and make our decisions based upon that. So it's not that, you know, you have to have been on, he was obviously, this young man was on, he said, for years on the corticosteroids. I think he said Emflaza, if I'm not mistaken. And so he would clearly automatically be approved for this drug if that doctor wanted him to have it. So that it's not that we require a long period of corticosteroids before someone could get on this. We just want to make sure that just like in the clinical trials, they were on it and we're continuing to decline, which is going to happen in a lot of folks, unfortunately. But we want to make sure that, I mean, for instance, if the corticosteroids are working and there's no decline, then there's, from the clinical studies that were done for Duvazat, it wouldn't warrant moving to Duvazat at this point. We do continue to monitor what clinical trials are going on for this and similar drugs. And to the point about the walking requirements, again, all we did was exactly match what was done in the clinical trials and what is in the literature, the prescribing information for this drug. So there are no data to support its use right now in someone that is unable to walk. So again, we're monitoring to see if the manufacturer is, and actually I think we're aware that they are doing some clinical trials looking at members that are unable to walk. But there's a reason why they're doing that, is because right now there are no data to support its use there. We don't know if it's a benefit or not. And so again, that's kind of, we've just set up our criteria to match what is in the prescribing information and what was done very clearly from the clinical trials that were done to register this product with the FDA.
Okay, thank you. No, that's helpful. So essentially you're saying that that Duvazat is approved concurrently with corticosteroid therapy.
Oh, yeah.
And you're just
Yes,
looking
this was
for,
definitely- yeah.
if the condition progresses to where steroids are no longer effective, you bring that on. I'm totally
That's
supportive of that.
Okay.
Can I, Chris, if you don't mind, we also, this is not going to be covered as of September 1st because the manufacturer has elected not to sign a drug rebate agreement with CMS. And just as a reminder to this group that if a manufacturer elects not to sign an agreement, the drug is not able to be covered by any Medicaid program. So right now, this drug is not covered in any of the 50 states or Puerto Rico. The market access folks have told me they're not inclined necessarily to sign the MDRP agreement. So this will actually, it's not a coverable drug. And even if the criteria were to go in place on September 1st, we are not going to be able to pay claims because the manufacturer has not completed their end of the deal that's mandatory for coverage. So
Thanks, Leslie. That's unfortunate, isn't it?
Yeah,
yes.
this is Dr. Marshall. I don't know I know there's a lot of new drugs for muscular dystrophy, but do we, and I don't know what they all do, to be honest. So do we have other options that these patients will be able to be switched to if they're on it, or?
Not in this particular class. And we, by federal law, cannot cover this drug.
No, I understand that, but what's the Saripa drug? That doesn't meet the
what now?
He's talking about Sarepta. So they're
Elidus? Is it Elidus or by
That's a
Sarepta?
completely different.
they're different mechanisms, so they work differently.
But they're not eligible for, they have to, okay, so
So
it
it
has to meet
depends
guidelines.
because those are exon skipping therapies, so it depends on what genetic makeup they have and which exons are skipped as far as which drug they can use. Then you have the steroids for Duchenne, and then you have this Duvizat, which acts differently as a non-steroid.
Okay.
So I want to make sure this young man understands and is clear. If indeed the drug has not chosen to play or participate in the Medicaid program, we are not allowed to cover it by federal law and by state law. So it's unfortunate that the manufacturer is chosen not to allow, by default, not signing the rebate agreement. They have to basically sign up with Medicaid for their drug to be allowed to be approved, and we would not be allowed. I apologize, we wouldn't even have done this whole PA thing if I'd been aware that they were electing not to sign up. So that's a whole other thing. So, but we can have the PA criteria approved, and if in the event that they do elect to participate in the MDRP, we could implement it upon their approval or upon their signing out. So.
It looks, so Mindy Cameron, are you wishing to provide public comment as well?
Yes, it's about the same topic. I just wanted to say, thank you for explaining why there's no coverage for this drug yet. I believe that in time, those rebate agreements will be in place. And I just wanted to say that there are many patients with this condition in the state of Indiana who are not walking. And walking is a tiny part of life when you consider all these things that these boys want to do and what their future plans are. My son is a senior at Ball State University. He's not walked in a decade. He is interested in trying this drug as well. And the ambulatory requirement, yes, we do those things during clinical trials so we can prove efficacy, but that doesn't mean that the drug won't help maintain functionality in non-ambulatory patients. The label does not say ambulatory. The FDA approved it for all patients that can take it. So I just wanted to, when the time comes and a rebate is in place, I would encourage you to consider this fine line of walking is not really what it's all about for these guys. Thank you.
Thank you.
And I'll throw in,
I do want to
understand-
mention too.
Go ahead, Leslie, I'm sorry.
Oh, I was just going to say, I do want to mention too, Medicaid, when we look at these types of drugs and we require that their members be similar to the clinical trial, or we require coverage based on the clinical trial, Medicaid is actually statutorily prohibited from paying for experimental use. So that's a fine line that we have to walk. And in this case, with no real data that shows that this would be effective, that borders on experimental use, and we're prohibited from covering that. So hopefully the manufacturer will do some studies. Medicaid drug coverage is very different from the way drugs are covered in the private sector. We have a lot more rules. We can only pay for FDA labeled indications. We cannot pay for off label. So we have a really
It's not off label.
Small
it's not
area.
off label. Ambulatory
It's
is
off
not
label.
the label. It's not. The label does not say anything about
It wasn't
ambulatory versus
studied,
non-ambulatory.
and so there's no proof that it was effective, and that would be considered experimental use.
Okay, thank you for
Okay,
clarifying your
if public
stance on
comments,
that.
yeah, if public comment is done, Amanda, let's see if there's anybody else that wants to speak on this, and then let's continue.
Any other public comment today? I don't see it.
If boys are not declining on steroids, it says they can't take the Duvizat, and I don't. Yeah. I just wanted to say that one last thing.
Thank you. I think we have no other public comment at this time. I don't see any others. Appreciate everybody's time. Any old business that we need to cover today? All right, hearing none, that will take us into new business. We do have a new public comment proposal that we spoke with to the Therapeutics Committee and that we're now bringing to you all. And this is really around trying to make sure we capture everybody's public comment, especially now that we're virtual all of the time. We want to make sure that we have public comment lined up. We know who's going to be speaking. We're not missing somebody that maybe either couldn't raise their hand, couldn't shoot a message in the chat box, so that we have everybody captured. There are a lot of other states that are utilizing this method, especially now that we've gone to hybrid or virtual methods where people can't necessarily sign up like they do in the room, which is what we've historically done. And so public comment for Indiana Medicaid, there will be allocated time at the end of the meeting agendas for public comment. All speakers will be limited to 2 minutes. Additional time may be allotted by the board or committee members at their discretion for any additional discussions or questions and answer. For industry representatives and individuals solicited by or speaking on behalf of industry, comment will be limited to 2 speakers per product and 2 minutes per speaker. And only the first 2 registrants for that topic or product will be permitted to testify. Speakers representing reimbursed by or being reimbursed by industry may only present new product information, which is changes since the last review, or new products. And so how the registration process will work is for requesting public comment, they will fill out the form and we'll put it on the website. The form is also listed below. The completed form should be emailed or faxed to the website or fax number listed there. And then forms must be received no later than 48 hours prior to the start of the meeting. That's just so that we can have everybody lined up and together. And then once the form has been reviewed and processed, the registrant will receive an email response or fax response if that's how they send it, whether their request has been accepted or declined based on if we have more registrants, let's say for their drug product, et cetera. So for public comment related to a specific drug, Indiana Medicaid is asking that it be focused on how is the product clinically superior? Does the product have any specific advantages over others available to treat for the same indication? Are there new evidence, research results that should be taken into consideration? And what action are you asking the board or committee to take? The board committee does accept written communications, so public comment in the form of letters, handouts, manufacturer information, etc. As long as they don't contain personal health information, so please don't send us your PHI via that same email box. And then those communications are submitted to the Therapeutics Committee or DUR board, whichever group that they're meant to be sent to. At their meeting, we send that in their packet. These communications need to be received no later than 14 days prior to the meeting date, so that we can actually include them in the packet that's sent to that committee or board. Public comment will be presented as described above. The chat function of Microsoft Teams utilized in hybrid meeting is not intended, nor will it be included in the record for public comment. So this is an example of the form. This is the printable version, but there is actually an online fillable one as well. And so again, they have name, occupation, email, phone, information from them, the meeting that they're wishing to provide public comment to, and their drug and topic of discussion. And then if it's new information or not, and then if they are receiving compensation for speaking, and if they're employed by a manufacturer, and then gives them the information on where to send this in. We do plan on including a slide then in the slideshow that will list all the public comments, people who are providing public comment, so that we can go through each individual person and make sure that they're captured in their public comment, whether they're in person or online. Any questions about that item of new business? And this, once you all vote for this item, this would be effective for the October meeting and on. So our October MHQAC, DUR board, and then November PNT committee. Do you want me to take a separate vote for this, or just go through new business too?
Let's take a separate vote for that one, yeah, thank you.
All right, if we have no questions or comments, if we could get a motion and a second on the public comment.
I'll move to approve.
Dr. Class, second.
All right, we have a motion and a second. Dr. Marshall?
Aye.
Dr. Class?
Aye.
Ms. Fippen?
Aye.
I'm pretty sure Mr. Johnson had to leave, so Dr. Opp?
Aye.
Dr. Simon? Who is Dr. Simon too? Dr. Simon is, all right, she on mute. Yes. I'll come back. Dr. Toma?
Aye.
Dr. Treadwell?
Aye.
Dr. Simon, can you hear us?
Aye.
Thank you. All right, we have all ayes, so that motion will carry. Thank you. We will then go on to our other new business. So for the agents for MASH and MASLD, Resdifra adding the FibroScan controlled attenuation parameter to approval criteria as an acceptable method of diagnosing steatohepatitis. For the allergy-specific immunotherapy PA, Palforzia updating the age limit to include 1 year of age and older. On the antiviral monoclonal antibodies PA for Synagis, removing the statement about lack of Beyfortus availability will be considered a medically justifiable reason for use. We have been assured there is enough Beyfortus availability. If that something changes, we will certainly bring that to you all. For the complement inhibitors PA, Solaris and Ultomiris, updating the following criteria and verbiage around diagnosis of atypical hemolytic uremic syndrome to inhibit complement-mediated thrombotic microangiopathy, and all of the following, and then it goes into the other criteria. For the muscular dystrophy agents PA, Dubizat, FYI only, updating the criterion around member has trial and failure of at least 90 days of therapy with Agamree or Emflaza as single agent therapy as confirmed by claims history chart documentation or provider attestation, and then prescriber has provided medical justification medical justification for use of Dubizat prior to trialing either Agamree or Emflaza as single agent therapy.
Is this the one we just talked about?
Sure is.
Yeah. We're just
updating language.
Yeah, we're just updating the language to make sure it's clear that all we're doing is requiring them to have been on one of these agents, but there's nothing in the criteria that says that you can't continue it. That's the point that we're trying to make with this. It's just a clarification to our criteria.
Okay. And I want to go back to that MASH one. Are there other guidelines to get diagnosed with steatohepatitis in the
Yes, there's several. We're just adding this in as an additional.
Okay.
Any other questions before I move on to the now phosphodiesterase inhibitors for COPD-PA?
Okay, it's kind of hard to see. It's kind of hard to add these without knowing what the rest of the policies are, to be honest with you. But go ahead.
We send out all the criteria to you in your email, so you get the entire criteria list.
Okay.
We're just trying to keep if we put all the criteria on the PowerPoint, it ends up being a really, really long PowerPoint. But if you want us to start doing that, we can consider that.
I'll start printing it out. Okay. All right.
For the DUR updating to include initial and reauthorization criteria and providing further clarification for step therapy or adjunct therapy expectations, just so that we're consistent across that PA. On the non-SUPDL PA and step therapy PA, myhibin suspension or mycophenolate, adding the following step therapy for previous trial of reconstituted mycophenolate suspension, which is the generic CellSub suspension, as confirmed by chart notes, et cetera, that we usually do, or medical justification for use of myhibin suspension over the reconstituted mycophenolate suspension. And then also including reauthorization criteria that permits for continuation of therapy. And then Voquezna, adding diagnosis of symptomatic non-erosive esophagitis with gastroesophageal reflux disease requiring heartburn relief to approvable diagnoses with the following criteria: that the member has tried and failed 1 standard dose of proton pump inhibitor for 4 weeks and 1 standard dose of histamine 2 receptor antagonists for 2 weeks in the past 6 months, again, as confirmed by claims history as we do, or the prescriber has submitted medical justification for use of Voquezna. And then the requested dose and duration of therapy will not exceed 10 milligrams once daily for 4 weeks. And then they may be approved for 1 course of therapy every 6 months. And the member is 18 years of age or older. For Pompe disease, for the Lumizyme, adding that to the criteria where they must have a diagnosis of Pompe disease confirmed by either deficiency of acid alpha glucosidase enzyme and GAA genotyping or gene sequencing, prescribed by or in consultation with a geneticist, metabolic disorder specialist, or neurologist, and the prescriber attests that member will not be using Lumizyme concurrently with Nexviazyme, Opfolda, or Pombiliti, and the dose requested does not exceed 20 milligrams per kilogram every 2 weeks. Then also adding reauthorization criteria around use for 90 days as confirmed by claims history. And then prescriber has submitted documentation supporting improvement or stabilization of disease. And then again, the same attestation that they're not using it concurrently with Nexviazyme, Opfolda, or Pombiliti, and that the dose is not exceeding the 20 milligram per kilogram every 2 weeks. And for Nexviazyme, initial criteria is that the member is 1 year of age or older, diagnosis of late onset Pompe disease confirmed by one of the following, and again, the same deficiency of acid alpha glucosidase enzyme and the GAA genotyping or gene sequencing, same prescribed by or in consultation with a geneticist, metabolic disorder specialist, or neurologist. Prescriber attests that they will not be using Nexviazyme, surprise, with Lumizyme, Opfolda, or Pombiliti, as the other criteria was, and then we have dosing listed there for you. And then reauthorization is again 90 days of use of the agent, that they're not using it concurrently with the other agents, and then again the same stabilization or improvement of disease and the dosing that was listed earlier. All right, OTC drug formulary and SUPDL, cetirizine 1 milligrams per mil syrup and loratadine solution, updating their step therapy to state member is under 12 years of age or unable to swallow the tablet formulation, max age of 18 years, and then we have a quantity limit of 10 mils per day. for vaccine updates, Afluria, Fluad, Fluarix, Flublock, Flusilvax, Flulavil, too many FNLs, Flumist, Fluzone. This is actually something my son started with in speech. Maybe he gets it from me. Maintaining those current edits and updating the naming convention to remove the quadrivalent from the titles because there are no quadrivalent formulas available for the 2024-2025 season. And then Fluzone HC updating the quantity limit to 1 dose per season, and it's the 0.5 mLs. It was previously 0.7 mLs per dose. I'm getting there, I promise. So preferred brand drug list updates. Additions to the preferred brand drug list are none. We do have some removals. So the Banzel 400 milligram tablets will be removed, but maintaining the 200 milligram strength. Carafate suspension is an FYI because they've discontinued it and it's not available. Intolense 200 milligram tablets. Those are removed, but maintaining the 100 milligram strength. And the 25 does not have a generic. Samska tablets and Vasipa capsules. And that is all of the new business. I don't know about anybody else, but I'm a little tired after that. Any questions or comments regarding any of that criteria from the board? If not, if I could get a motion and a second, please.
This is Dr. Marshall, move to approve.
This is Carol, second.
Okay. We have a motion and a second. So Dr. Marshall.
Aye.
Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Dr. Opp.
Aye.
Dr. Simon.
Aye.
Dr. Toma.
Aye.
Dr. Treadwell.
Aye.
We have all ayes, so that motion will carry. Do we need to ask Dr. Marshall or?
I just would ask him if he's ready to go to the last agenda item.
All right, Dr. Marshall, we are on the last agenda item if you are ready to adjourn us.
Yes, move to adjourn. I got to go. Thanks.
All right, thanks, everybody. Appreciate your time.
Nice job.
Have a great
Thank you.
weekend.
You too.
Uh-huh.